Sure. So this came from the same data set, and in this data set we were looking to see whether what features made someone more likely to have MRD positivity, and then once a patient did reach MRD negativity, what happened to them. So for this analysis we had about 1,350 patients in total across the two studies with NPM1-mutated AML. About 1,000 of those had samples for sequencing for mutations, and about 800 had an MRD result. What we showed was that in terms of what factors made you less likely to become MRD negative, that really important time point we've shown was the DNMT3A mutation, the FLT3-ITD mutation, and another mutation in a gene called WT1, which many people don't think about in NPM1-mutated AML. And so the presence of any of those mutations significantly reduced the likelihood of achieving MRD negativity. And in particular, the combination of FLT3-ITD and DNMT3A, which is known to be a bad combination, was the lowest likelihood of achieving MRD negativity. Once a patient does achieve MRD negativity, what we showed is actually in that situation FLT3 no longer matters and doesn't increase the risk of relapse or death, whereas the DNMT3A and the WT1 mutations do, as well as the increasing age, which is a very common bad prognostic factor in AML, and the baseline white cell count. Despite that, related to our previous talk, if you were MRD negative, regardless of all those risk factors, there was still no benefit to transplant. We also showed in this analysis that patients who received FLAG-IDA, which is an intensified induction regimen, had more MRD negativity and less relapse and better survival, and that was regardless of the baseline risk factors. And in fact, those very high risk groups, like very high white cell count, or the DNMT3A FLT3 mutated, or the WT1 mutated, seem to derive the greatest benefit from FLAG-IDA.